Well, good evening, ladies and gentlemen, and welcome to the Institute of Economic Affairs. My name's Ryan Bourne. I'm the head of public policy here at the IEA, and this is our second event in our Paragon Initiative series, which is the research series of work that we're doing over the next 5 years, fundamentally reassessing all areas of government activity. And the topic tonight seems particularly pertinent given what you tend to see in the news week in, week out. The NHS and healthcare in the UK has become one of the preeminent issues, and perhaps has always been one of the most preeminent issues in policy discussion terms. And we've got a illustrious panel here tonight to discuss the problems and challenges facing the NHS. I won't bore you with long and detailed biographies of all of our speakers. I'll just introduce them very briefly. To my immediate left, we have Dr. Kristian Niemietz, who's Head of Health and Welfare here at the IEA. He's also author of the forthcoming IEA publication, Diagnosis Overrated, The Structural Flaws of the NHS. To his left, we have Lord Bichard, who's the Chair of the Social Care Institute for Excellence. To his left, we have James Bartholomew, who's the author of The Welfare State We're In and The Welfare of Nations, which, pertinent to this debate, has a chapter on healthcare in which he explores different healthcare systems from around the world. And finally, we're joined by Emily Crawford, who's the Research Associate at Respublica and author of The Care Collapse, The Imminent Crisis in Residential Care and Its Impact on the NHS. I'm going to ask each of the speakers to just offer some thoughts for between 5 and 7 minutes to start the discussion, then we'll open out into a chaired Q&A. So we'll work along the line. So Kristian, over to you.
Yes, thank you, Ryan. About a year ago, the IEA published my first paper on health reform, in which I argued that the NHS was lagging behind most comparable systems on most health outcome measures. And I remember some people got very angry about this on social media in particular. Some said, how dare you denigrate our NHS? It's the best system in the world. The Commonwealth Fund has just proven that, and that's the definitive proof. The science is settled. Everything else is lies and smears. Now, last week, the OECD published its new report on health outcomes and showed, well, no big surprise there, that the NHS is, in terms of outcomes, one of the worst systems in the developed world. I was expecting that, especially all these Save Our NHS campaign groups, that they would either pretend that that report didn't exist, or that they would only mention it in the sort of dismissive, move on folks, there's nothing to see here way, because that's what they've done with previous editions of such reports. But this time they didn't. Interestingly, they did pick up on it, and that was because this time they could integrate it into their narrative. This time their spin on it was, oh look, there you go. Yes, the NHS has become one of the worst systems in the world, and that's because this government is destroying it systematically. Now there's a bit of a problem with that. If you look at the actual OECD report, you will find that it doesn't contain anything that's fundamentally new. What it really is the OECD has updated its healthcare database, and that report is just an extract from that. And if this narrative about that report were correct, what you would expect to see in the data is a recent sharp drop. You would expect great outcomes a couple of years ago and then a sharp decline at some point. That is, of course, not at all what you observe. In fact, what you do see in that report is that the NHS in outcome rankings is pretty much where it's always been. Somewhere in the bottom third, depending on what indicator you're looking at. It's ranging somewhere from mediocre to poor, not catastrophically bad on any single measure, but overall clearly not impressive in any way. And there's absolutely no discernible time trend here. The only thing that's really remarkable about that report is that how unremarkable it is, how little there is that should really strike anyone's attention. So if you use this report in order to argue that the NHS is one of the worst systems in the world, then you cannot also simultaneously claim that it has ever been a wonderful system, because there's simply not enough of a trend and not enough variation over time in the data. Now, if we use that report to look for alternatives, then it gets a bit trickier, because there's no system that clearly comes out as better than all the others. There's no single country or not even a single type of system about which you could say, yes, that's definitely it, that's the way to go. There's too much variation that has no obvious explanation, but there is a little bit of a pattern. It is overall fair to say that, firstly, it's not just the NHS that's doing poorly, its closest relatives, systems that are most similar to the NHS, like the Irish system, like the Danish system, they seem to suffer from some of the same problems. So there are some commonalities here. And on the other hand, on the other end of the spectrum, some of the pluralistic competitive systems where you have a diverse provider sector and a high degree of patient choice, are usually not too far away from the top. So the Australian system, the French system, also the social insurance systems that I've written about, the Dutch system, the Swiss system, they are also quite consistently among the best performers. The only reason why that seems to surprise a lot of people is that here we often like to pretend that the world only consists of the NHS and the American system, whereas the American system is in lots of ways completely atypical, and it's also atypical among that specific group of pluralistic systems with a high degree of private provision in it. Now, I am aware that some of these competitive systems are also that they are more expensive than the NHS. That countries like France or Switzerland spend something like 11-12% of GDP on healthcare, whereas here it's just under 10%. So if your main priority is to keep costs under control, then you would not introduce a system of that kind. That is easier in a single-payer system to control costs, simply because the government of the day directly sets budgets. But I would be careful with interpreting those figures, because low spending does not automatically mean high efficiency. In fact, the OECD has also produced an estimate of health system efficiency, where they have modeled different healthcare systems as production functions that turn input factors like funding levels and staffing levels into health outcomes. And they've tried to control for lots of factors, especially lifestyle, dietary habits, how prevalent are smoking and drinking, and education levels, and all these other things that usually make comparisons harder. And on that estimate, on that measure, they also find that the NHS is actually one of the least efficient systems. So there is no automatic link between spending levels and efficiency. Is actually some of the expensive systems. The Swiss system here, maybe an extreme case, is one of the most expensive systems in the world, but it's also, on that estimate at least, one of the most efficient systems. So it is possible to spend large sums of money efficiently, and it is possible to spend relatively small sums wastefully. Now, having said that, I'm not opposed to higher levels of spending. If people are prepared to spend more on healthcare, then that's fair enough. If that's what people want, if they're prepared to pay more, then who am I to complain about that? All I'm saying here is that we're not likely to get that as long as the service is almost exclusively tax funded. Simply because the country, the economy, is close to the limits of taxing capacities. There has never been, at least not during peacetime, a much higher take of the economy raised in the form of taxation. And that is where there is a big difference between single-payer tax-funded systems and insurance-based systems. Because in an insurance-based system, the insurance premium is more or less a price like any other. it's not fundamentally different from, say, the price of potatoes or the price of wine. And if potatoes and wine become more expensive, we may not like it, we may be unhappy about the fact, but we wouldn't say that this causes wider economic distortions. We wouldn't say that this decreases the labor supply or the savings rate or whatever it is, whereas higher taxes clearly do that. So it is possible to spend more on healthcare, but then we would have to diversify the funding side as well, either in the form of insurance premiums or simply of co-payments, of direct user charges, something like deductibles, that you spend a certain amount yourself before insurance protection kicks in, or in the form of proportional co-payments. And I think that's the way to go. Move towards a system where the provider side is much more diversified and competitive, and where the same is true on the funding side, where the system rests on several distinct sources of funding, with ideally most of them being less economically distortionary than taxes. Thank you.
Well, thank you, Kristian. Lord Bichard.
Yeah, I want to preface my contribution with 3 comments. First of all, I'm not going to talk about money. I am prepared to accept there's a funding gap. I am. And I am prepared to accept that other countries do spend more on health. I just don't believe that pouring more money into our existing system is necessarily going to improve outcomes any more than it did in most of the other public services over the 10-year period from 1998. So I'm not going to talk about money. I just want to make it absolutely clear, I'm picking up your point, that I believe the National Health Service is populated by amazingly talented and committed people. And that's not irony, I believe that. And you have to say that because if you go on to criticise or ask questions about that system, then you do get vilified or criticised. So I just want to make it clear, this is no, I'm not asking questions about the commitment of the staff. And I also accept that there are pockets of good practice around the country, because whenever you talk about public services in this country in a critical way, people always point you to something that's happening in Grimsby, which is absolutely fantastic. The trouble is that pioneers, vanguards, initiatives and pilots don't make for a transformed system. I think the NHS, the health system in this country, faces 2 sorts of challenges. The first derives from changes in, I keep using the word clients because actually I have a problem with patients, but it derives from changes in client groups and demography. And yes, I've spent quite a lot of time recently looking at older people and their experience of social care and health. And clearly there's a major growth in that client group, but also with people who have got diabetes or pre-diabetes symptoms. So that's one kind of challenge. The second challenge derives from the way in which the NHS behaves, its culture, its history. And when you look at that through the prism of, say, an older person with complex conditions, then I think it causes you to ask some quite searching questions. Now, I ask questions now, not only am I chairman of Sky, I'm also chairman of the National Audit Office, and that's taught me not to be too dogmatic in my public statements, but merely to ask questions. So I'm going to ask a series of questions, really. I mean, the first question is this a system, is this a service where professional boundaries are still too rigid? Because if it is, then that will mean that services are often fragmented. They can look confused from the point of view of the user. They can be difficult to access, and they tend to be more convenient for the provider than they do for the user. So is it too rigidly demarcated? Because if it is also, as Lord Carter, I think, has argued recently, productivity can be seriously impaired because it's very much more difficult to manage the workflows. So do we still have a system which is too regimented and where professional boundaries in particular are too rigid? Do we have enough people in the system who really understand how you design services? I chaired the design council for a while. I'm a bit of a geek on design. You do not get high quality efficient services anywhere by accident. You have to design them. Do we have enough people in our health system who understand service design, who can commission service designers? Because it seems to me the only salvation for the NHS and the health service in this country is a radical redesign around clients. Which brings me to my third question. Is there much evidence, is there enough evidence of co-production and co-design? I'm one of those geeks who've been involved in public services for most of my life. The last 30 years I've been involved in trying to modernise our public services. I'm prepared to accept that largely my generation has failed. And I'm increasingly of the view that one of the reasons that we failed is that we haven't involved users, citizens and clients early enough in the process, not through some sophisticated system of consultation, but actually give them the power to influence and shape the services. Do we see enough of that happening in the health service at the moment? Well, actually, if you look at the report from the Picker Institute back in 2013, they don't think you do, because they said that despite strong official commitment to patient-led service, our results suggest the UK is not performing well. And it hasn't got better since 2013. So is this a system which is good at sharing power with individuals and with users? If it is, perhaps we wouldn't have so many people dying in hospital when 67% of people want to die at home. Is it a good partner? Most of the issues that older people face cannot be resolved by one institution, whether it's the NHS or a local authority. It requires there to be good relationships, constructive partnerships. Is the NHS good at building partnerships and coalitions? Is it good at sustaining them? Because if it isn't, the people who suffer are the clients, the users. Has it yet got the right balance between, I could answer some of these questions, I'm not going to, you can answer them. Has it got the right balance between acute services and care? Or are we still looking at a system which is more focused upon acute services? People laugh at me when I say the public service ought to have a look at the fire service. Fire service actually 25 years ago was totally an incident-based service. It isn't anymore. It's a service which is focused on prevention. And some of our other public services could learn a lot from that service, and actually the NHS could learn quite a lot. I think the NHS could actually work with the fire service in more imaginative ways too. Are we looking at a system here which is still too risk averse at a time when actually we need innovation and creativity? It's a British disease to believe that you can't do anything about that. You're either given creative people or not. I don't believe in that. My experience has been that creativity and innovation derives from the kind of leadership, from devolved responsibility, from the imaginative use of technology, and from being an organisation that is willing to learn from failure, read Matthew Syed's book, and learn from external partners. Are we looking at an NHS which is like that? The last two, have we actually seen a system here which is good at realising the potential of technology? You could argue we have in clinical settings, but have we in other settings? For example, are we using technology to enable older people to live independently at home? I think we've been quite slow in achieving that compared to other countries. So are we really as good as we say we are in the use of technology? And finally, I mean, is our strategic planning too short term? I sat on the Barker Commission recently looking at health and social care. We tried to take a 20-year view, and our feeling was that over a 20-year period, okay, you had to establish priorities, but there were ways of dealing with the growing numbers of older people. But you did need to take a strategic view. Have we done that in this country? You could argue if we haven't, that's largely the fault of politicians and not of the health service. And I actually don't believe in suggesting the service has become too politicised, because we live in a democracy, and I think politicians should have a major say in the way our fundamental services are delivered. But yeah, I would like to see a bit more courageous political leadership. If you get those things wrong, if you answer those questions negatively, then you will end up with a service which is fragmented, inaccessible, inflexible, delivering poor outcomes. It's actually can be very expensive. And sometimes, because it's not involving users early enough, it can deliver things that they see as irrelevant. I say, I'm just posing the questions.
Thank you very much. James, over to you.
Can I stand up? Would you mind?
Yes, that's fine. So long as our cameraman's fine with that.
Cameraman, are you happy? Nice. I'll just join civilization. I wonder how many people here have heard of Dorothy Martin. She was a woman in the early 1950s who lived in Chicago, and she thought that she was being communicated with from an outside place, and she started writing things on a pad of paper. Anyway, she came to believe that an apocalypse was about to happen, and that the whole of the west of America was going to be deluged, and that the only way they could save the world from this catastrophe would be if true believers gathered together, and then they would be a flying saucer would come down and save them from Chicago and take them up from this apocalypse, and they would be all right. And she persuaded persuaded other people that this was the case, and they all got ready for this coming disaster. And there was an academic noticed an article about this in the paper, and decided in the days before there were lots of rules about what academics did, that they would infiltrate this group of people who believed the world was coming to an end, and see what happened if, as they sincerely hoped, the world was not going to come to an end. And so they infiltrated this group, and so they could watch close up what would happen, where would their belief go when the world didn't end. And so the appointed moment on December 21st, 1954 came, and the clock went down, and the flying saucer didn't come, and the world didn't end. And what did they do? They sort of waited. They were a bit upset. They waited on till sort of midnight, till 4 o'clock, getting rather upset. And then they began to find some excuses. Actually, by being there and believing, they had averted the disaster. You know, they found any kind of excuse to believe, go on believing. And this desire to go on believing is a phenomenon that is widespread. It has happened in, for example, Jehovah's Witnesses have also, excuse me if there are any Jehovah's Witnesses here, but they have predicted the end of the world several times. And each time it has failed to end. And yet there are 7 million believers in Jehovah's Witnesses today. They have not been put off by the complete failure of the world to end. Now, you will not be surprised to hear that I'm drawing a parallel with the NHS. The NHS, and I happen to have with me the 1943 document issued by the Labour Party on a national service for health. It was going to be the NSH, but it got changed. And in this document, you will find, among other things, that consultants were going to visit people in their homes. Yes. If you were ill, consultants were going to visit you. Not that you wouldn't have difficulty ever seeing a consultant, they would come to you. And hospitals, you know, they had to be kept local. You know, whereas, as you may know, the NHS has closed literally hundreds of hospitals. So they were promising a first-class service for all, and it hasn't happened. I mean, you may have thought, when it was initially created in 1945, you might say, well, they haven't had time yet. They've just expropriated all the existing charitable hospitals and all the local hospitals. They've expropriated all those. They expected to get brilliant overnight. So years passed and still didn't get brilliant. They had waiting lists, rationing. Hospitals were closed en masse. En masse. In fact, not far from here, St George's Hospital. That's now a hotel. That was a charitable hospital. A massive one in central London, closed down. Anyway, I in research for the book, which I happen to have a copy of, if anybody wants one. There's a book. I travelled around the world and looking for healthcare systems and comparing them. And I took 9 measures. This is an amateur assessment of healthcare systems. 9 measures of healthcare systems. And see how different countries did. And in 6 of those measures, Britain was among the worst performers. Among the worst. None of the measures was it the best. None. Not one. And the measures on which it was among the worst were quite important things, like breast cancer survival rates, colorectal cancer survival rates, MRI scanners per person, CT scanners per person, number of people waiting more than 2 months to see a specialist. Anywhere. Not at home, anywhere. It's among the worst in the world. And really, Britain was an outlier, because generally, one of the strongest correlations with healthcare performance is wealth. And so if you basically wanted to improve healthcare, you could just make the country more wealthy. But outliers do exist, and one of the outliers on the downside is Britain, because it's a relatively wealthy country which has a really poorly performing healthcare service. So I'm convinced, and the extraordinary thing is people go on believing it. I mean, this is the extraordinary thing. It's like the Jehovah's Witnesses. People go on believing despite all the overwhelming evidence. And I puzzled over why this is the case, because it's really frustrating for those of us who see the evidence and want something to be done about it. Why do people go on believing it? And I mean, you can't see inside people's minds. I guess it's partly because there's a certain conservatism. Ironic, considering it was created by a sort of neo-Leninist who wanted to have a, it wasn't actually in the Labour Party manifesto. He just sort of, Bevan took it over and said, right, we're going to go the whole hog. And he was brought up in the idea of Leninist absolute revolution that can't be reversed. And now conservatives all over England think, oh yes, it's what we have, so that's what we want to keep. And that's part of it. I think part of it is the belief that everybody else believes in it. And so, most people do believe in it, but not everybody believes in it. But in the public discourse, everybody says they believe in it. So I think that is a factor in it too. I think there's a very powerful idea that whatever your circumstances, if you have a terrible accident, you can go to a hospital and you will be treated and nobody will ask you about money. I think that's really powerful psychologically, even if another part of them knows that if their mother is dying of cancer, she's more likely to survive. She's in France. But they keep that in the back of their mind because they don't want to think that. This is a place that studies political economy. It almost should be studying psychology because this is a major obstacle to sensible reform. And one of the reasons I think people don't think, yes, we ought to change this system, is because they have no real knowledge of the rest of the world. They have no knowledge. I mean, this is a map of the world. This has all the countries in it. And if you were going to go on holiday, you would think, oh, shall I go to France or Germany or Switzerland or India or Australia or Singapore or all sorts of places you can go. There's a map with lots of, when you're going on holiday, there are lots of different countries. But if you're thinking about healthcare systems, Germany disappears, France disappears, Switzerland disappears, Singapore's not there. Actually, all these countries disappear. There are only 2 countries left in the world. That's all they exist. All the others are destroyed. There's just Britain and America. That's it. Finish. Because that is the level of the public discourse. People have no idea of what's going on in other countries. Having said the gloomy part, I mean, I'm trying to be optimistic. I think that some of the belief in the NHS is skin deep. And there's various reasons for believing this. And I think that other countries, we know that it is possible to change. The Netherlands had a system not dissimilar to ours 30 years ago. But they realised things were going wrong. Similar sort of things have gone wrong in the UK. Things like rationing, waiting lists, hospitals not doing operations because they'd run out of money, things that didn't seem very good. And so they set up a commission run by a man called Bichard in 1987. He reported and said there should be more competition and private sector involvement in healthcare. And gradually, in a sort of torturous process, the Dutch they're very keen on consensus. They've built up consensus and made little moves one at a time, and gritting their teeth have gone to the next step and the next step, and continually reforming and very sophisticated, very slow. But they've actually, although they're slow, they've actually been a tortoise that's finally got most of the way there. And now they have a system where everybody has private, or can have private healthcare through an insurance system. Everyone pays the same. Those who can't afford it don't have to pay. It's a system that is very similar to the Swiss system. It's a vast improvement. They don't have the kind of problems they had before. Another reason why I think it's skin deep is this article here. I mean, there are many reasons for thinking the love of it is skin deep. This is in the Daily Mail earlier this week. The NHS, not for them, you provide private healthcare for town hall bosses. And it mentions in it Labour-run Redbridge Council. And they have such admiration for the NHS that 13 of their bosses have private healthcare. So it's one of those things where there's a sort of people think on two levels. On the one hand, NHS is marvellous. On the other hand, actually, I'd rather have private healthcare on the quiet. And I think there's a lot of that going on. And obviously, what I would like to see is not trying to improve a system which is a government monopoly, which we would never want to have in any other area. You wouldn't want your shops to be a government monopoly. You know how grim that would be. You wouldn't like your holidays to be a government monopoly. Can you imagine the 4-hour target time for the departure of the aircraft? I mean, it's crazy that something that's so important as the healthcare is something that we wouldn't trust on anything else. So I hope that we'll get to a stage where we all have private healthcare, everybody, not just Labour council bosses. Thank you.
Thank you, James. Over to you, Emily.
Thank you. I'd like to touch on some of what Lord Bichard picked up in the light of the report that Respublica published yesterday about the issues affecting the residential care sector. And I want to preface my discussion of the residential care sector by just slightly widening our conversation this evening. We've been talking so far by my very esteemed colleagues about the NHS in and of itself, but the NHS is the health and the care sector systems are closer to an ecosystem, and the NHS and hospitals, you might say, are like the lions in a jungle, or the lions on a savannah actually, but the lions need to eat antelopes, and the antelopes need to eat grass. So there are very many important players in an ecosystem, of which the NHS is perhaps the top dog, but where there are also important other players. And one of those is the residential care sector, because what happens in other parts of the system has a very immediate and clear knock-on effect to the NHS services. So what we were concerned to look at in our report that was published yesterday was the current operational and financial and the nature of the challenges facing the residential care sector. This is a sector that looks after nigh on 500,000 people, 1 in 6 people over the age of 85. They are a very, very important part of the care landscape, part of that ecosystem, and they are facing some very, very real challenges at the moment. There, as we all know, it's no news to anyone in this room that there is an ageing population, and at the same time that we have experienced some, as a nation, some very challenging economic circumstances, which has led to, funding cuts, and in a system which is at the moment publicly funded, that flows through to the money available for public services, and in particular to residential care. So we were really interested to see, well, what's been happening in the sector, and it is very, very alarming. The operational viability for care homes is really on a knife edge. In the past 5 years, the rise in their fee to care for an older person has barely moved, and yet, obviously, we all know the cost of living has moved, and so what we did was we modelled what the expected demand for care would be in the forthcoming 5 years against the expected funding for that care. And there is, I think a few years ago there was a reference to a graph of doom. This is the scissors of doom, and you can see that within 5 years, by 2020, the demand for residential and aged care sort of goes like this, and the funding for that care goes like that. And the gap between the two comes in at just over £1 billion. That puts this sector, which plays a very important role in caring for some of the most frail and elderly and ill, in a very invidious position. And so our second question was then, well, what would happen to those 500,000 residents if the situation were such that the care homes were no longer able to provide that care? I think perhaps some of you may remember 4 years ago when the Southern Cross chain of care homes failed. There was about 30,000 residents, and they were absorbed by their co-care homes. And I mean, that is a very upsetting and regrettable process, and that process does have a mortality effect, because we're talking about very frail people. Shifting them physically from one institution to another is very negative. It has really negative health impacts on them. What we were concerned about is that the funding situation in the residential care sector could lead to another Southern Cross. So we modelled, well, what does 1 billion funding gap in 2020, what does that mean in terms of a potential number of beds in care homes? And it came in that £1 billion is worth 37,000 care beds. And then we said, well, what are 37 care beds worth to the NHS if all of those people flooded into the hospital system? Because bear in mind, now we're now 4 years on from Southern Cross, and there's less capacity in the sector to mop up that excess demand and rehouse all those residents that might be homeless due to sector failure. So we thought, well, what is 37,000 lost beds worth in NHS terms? And of course, an NHS bed is about 3 times the cost of a residential care bed. Even if you calculate it on a fairly low level of sort of medical attention, just a fairly general ward. We're not talking intensive care costs here, we're talking a fairly general care cost. And should that failure in the residential care sector flood into NHS services, you're talking about £3 billion worth of beds that would need to be found in the NHS sector to deal with very, very frail elderly people. So I want to just bring this discussion back. I am talking specifically about a particular sector, one that is both publicly funded and privately funded, and one in which the private patients are at this point cross-subsidising the public patients because the public system is either unable or unwilling to provide a fee for service that actually reflects the cost of that service. So you have a situation where there's sort of part of the population is cross-subsidising another part of the population to the detriment of the service. And I guess I just want to use this as an example where we need to think about the system as a whole. It is important to think about how the NHS can and must change in the face of rising demand from an ageing population. This is an absolute essential. It's a must. I think we've all read any number of reports. The Barker report in particular was absolutely spot on. But I think we need to see this as an ecosystem, as a system in the whole, and really take it from the patient, the resident's point of view, the person's point of view, because at the moment I can't remember if it was you, Lord Bichard, who described this as fragmented, and from a service user's point of view, it can feel very confusing. So taking it from a systemic point of view and considering the kinds of radical transformation around both funding and service design, I think that's very necessary. And in the case of residential care can and must play an important role in whatever form a reshaped and a personalised service and far more integrated service looks like. Because otherwise, and that care must be valued and funded to an appropriate level, because we do risk otherwise the antelopes fleeing and the lions have nothing left to eat, and it'll have a £3 billion impact on some very important services which should be dealt with elsewhere down the line. So I'll leave it there if that's okay, Ryan.
Thank you very much, Emily. Just before I open it out to Q&A, just use my position as the chair, abuse my position of the chair to make 2 observations. One of them is talking about joined up thinking in policy terms. Of course, the introduction of the national living wage and other policies is going to have a huge impact on the care sector, as many people in the care sector have actually warned over the past 6 months. But I was particularly struck actually by something that Lord Bichard said when you were talking about productivity. It's a very sort of economic term to use, and people tend to dislike it when you use it in association with sectors like health or social care. But if you look at the Office for Budget Responsibility, publish a paper every year called the Fiscal Sustainability Report, and that shows quite clearly that the biggest determinant of the future direction of the public finances is not the ageing of the population, it's actually the degree of productivity in the healthcare sector. If it carries on at the level that it is, on unchanged policies, our debt over the next 40 years just completely skyrockets. So, it's easy for us to focus on ageing, but actually getting the productivity growth into these sectors is even more crucial in many ways.
Absolutely. On both points, I think that's very important on both points. So the national living wage, which comes in from next year, will, by our calculations, be about a third of that £1 billion funding gap that I referred to. And that's an unfunded commitment on private sector employers that they need to find from next year. And in the care sector, and I won't speak about the health sector, but in the care sector, there are very few productivity gains to be made because it's a labour-intensive industry. There are some, but the extent to which there can be productivity gains through perhaps in other industries through mechanisation or through back office approaches or IT are less in a care setting because it is a human-to-human service.
I left the care sector tonight to Emily because I knew she was going to talk about it. When I do chair the Social Care Institute, I just want to say I agree with everything she said. And I think one of the most interesting things, you described it as an ecosystem. It is an ecosystem. Is it accepted as an ecosystem, particularly by the NHS? And is the NHS well equipped to work in an ecosystem like that?
Well, having had some...
I wouldn't expect you to answer.
Well, I will. I can't resist. This is the advantage of working for a think tank, because you're allowed. The relationships that can be built, on the ground, can be amazing. Equally, it's a very slow process, and I think the Better Care Fund and the push to integrate the care and the health is evidence of just how much hard work needs to be done to build those relationships.
Yeah, I guess one of the beauties of working for a think tank, I described it to one of my colleagues as a bit like being a politician without having to worry about those pesky constituents and voters. So we'll open it up to the floor now, and I know that there's a lot of new faces in tonight. I imagine some people who work in the NHS, work in the care sector perhaps. So I'll open it out. I'll probably take 2 or 3 questions at a time. So who'd like to kick us off? Yeah, we'll go to one at the front and then the lady back there in the white.
Charlie Wolf, I'm a broadcaster. I want to thank all of you for your comments, but Kristian, I want to thank you. I've had to deal with the Commonwealth Fund on the radio recently, and your paper on that has opened up my eyes on how to tackle that. And James, I don't know if you remember, I interviewed you when the welfare state we're in came in. 2 questions, one for Chris, one for James. Chris, you were talking about maybe having co-pays, etc. Do you think that would work when we have this mindset here of, God forbid, someone should get something somebody else doesn't have, this whole 2-tier mentality? And then, James, would it be a simple analogy to use Margaret Thatcher's model for BA when she talked about when it was under state control, of course, it was an expenditure, every seat cost money, and then, of course, when it was privatized, it became a profit center. Does that analogy work, or am I off base on that one?
So we'll take the second question now as well. So the lady in the white.
Mine's more a comment to which I'd like the panel's view.
Could you just say who you are, what your name is, who you are?
My name's Catherine Wolford. I'm not medical, but I have a son who's had chronic illness from the age of 10, which is now 17 years, and a husband who's had cancer. So I've had a huge amount of contact with the NHS. And the few things I've observed are that, when Beveridge and Co. set it up, it was not intended to cater to a population of this size, this longevity, and with this number of complex possible operations. I think that the entitlement, the sense of entitlement a lot of people have, is one of the problems that leads to the NHS not working. You know, people turn up at A&E with a cut finger and expect to be seen in 10 minutes and don't realise that they shouldn't be there at all. And I think we perhaps should be considering charging for, you know, small charges for seeing a GP, for going to A&E, which might stop people who simply treat it as a family outing. I also work in a large paediatric pre-surgery ward as a volunteer, and my observation is that it would be ludicrous to have everything patient-led. I mean, firstly, the patients are children, and many of their parents are not intellectually up to making the sort of decisions that are involved with a very complex illness. And to suggest that the patient or the parent can lead that is, in my view, absurd. I think the sort of overall sense of entitlement people have about a system that is inevitably finite is mistaken. And as far as end-of-life care goes, you know, my mother's 92, she'd rather slit her throat than go into a care home. And I think that Atul Gawande's book, Being Mortal, takes a very sensible view. You know, people get old and frail. The end thing is we all die. And to pretend we're not going to, or that we shouldn't, or that we should be prolonged in an appalling state for the sake of being alive is mad. So.
Okay, well, thank you for your comments. So, lots to pick up there. I guess two of them were related, so I'll perhaps put these both to you, Kristian. There was the idea of co-payments, and then the lady after that mentioned the idea of small charges as well. So I guess, how realistic are they? How much of an impact might they have?
It would depend on how you introduce them. If a politician stood up and said, from tomorrow on, or from next year on, you have to pay the first £1,000 yourself, and then 10% of all the rest up to a cap or whatever, then that person would be hounded out of the country. It would never win an election or anything. But you could change the. It depends on what the default option is. You could have something like. In the Swiss system, insurers can offer health plans where you can opt into a version with co-payments, and you would get a premium rebate if you do that. So the default option would be everything covered for free, like now, but you can opt into this plan where you pay whatever they specified, first £1,000, first £2,000 yourself. Your premium goes down, or here in a tax-funded system, it would have to be a tax rebate. And people then make the choice. Are you prepared to accept some risk yourself, or do you want the all-inclusive service? And if you did it in that way, if you could communicate that nobody is forced into this tariff, people who do nothing would just remain in the current system as it is, then it could work, because then you could argue, well, what's the problem? If some people want to opt into that, that should be their choice.
On one of the other points that was mentioned there, I wonder if any of the panel would like to reflect on, was two almost sort of conflicting points, but both valid to a certain extent. One was, how much confidence do you have in the idea of patient-led healthcare? Are people informed enough to make the decisions on their own, to decide what healthcare services are required and needed? And then on the other hand, how do you go about reshaping health and social care such that people can make dignified choices at the end of their life? That seems to be an increasingly big issue. We've had the discussion of assisted suicide, which is one extreme part of that. But how do you go about developing a system where actually people have a certain degree of choice as to how they end their life, which is one of the biggest fears and biggest issues for many families out there?
I guess I want to pick up the co-production thing and co-design thing, but before doing that, the issue of charges is quite interesting. When we were looking at this in the Barker Commission, people were saying to us, well, it's obvious, you just impose some charges for GPs or A&E. The problem with that is you actually, by doing that, are making it less likely that people will access the system. And if you don't get people into the system, you're running up huge costs later. And therefore you want to encourage people into the system. When you start talking about charges for people who don't come to surgeries, I kind of feel pretty angry about people who don't turn up for appointments. As an ex-bureaucrat, I can tell you, as soon as you start imposing a penalty, you've got to have an appeal system, and so it goes on. And it just doesn't work out. it's not difficult, as the Market Commission report says, to look at ways in which you can get more money if that's what you want. Why do we have free prescriptions for all men over 60 when we don't give them a pension till they're 65? Why are we giving free travel to wealthy pensioners? Why are we giving free TV licenses? The reason is because these people vote, and there's not a political party in this country that's got the courage to face up to that issue. Now, you know, it's not a lack of money often. It's a question about political courage to establish priorities. I think on co-production, well, okay, you can say that you think people are not bright enough to be able to contribute to that kind of debate. That's exactly what architects and designers said 20 years ago. You know, it's no good asking these people their opinion. They don't really understand it. You wouldn't hear an architect or a designer saying that now. But okay, you need to structure this, you know, this conversation. But I can tell you, I mean, at Sky, we've run a number of roundtables recently. We always involve users. We always involve users in those, and it sticks in my mind that recently at one of those, a disabled person said, look, all these decision makers, I hear what you're saying, but I don't want you to have more money, because if they give you more money, you'll do more things I don't want. You know, and that's the situation you get to, and we can all talk about efficiency, but actually we waste a lot of money providing services that we think people want in the form that we think we want them, but they don't, and we've never asked them, we've never involved them in shaping that.
I think there's something to add to that as well, which it depends on the particular condition or point in the healthcare cycle that you're at. Now, critical surgery may well be a situation, and I would probably agree with this, where you very much want the consultant to tell you what to do. That's why they've been trained for 15 years. But in a situation where it is a long-term chronic condition, and where it is as equal parts well-being as it is your health, the where individual action can have a very positive impact on your well-being and the state of good health, then I think person-centered design is both more likely to deliver the kind of integrated, joined-up care where the person understands what is happening, and also it's more efficient. It means that there is not a failure demand. There's not constant calls which never solve the problem. So in a situation of diabetes, there's quite a lot of research about peer-to-peer education and I wouldn't say self-medication, but I mean like self-management. At the other end of the life cycle, you know, as a person gets older and more frail, the involving them and them being part of the decision-making process is about shaping a care package that suits their needs and which makes best use of the resources that are available in the system, so that the resources that aren't needed aren't wasted on them if that's not what they need. I think there's also something about, and this is a psychological element, I'm going slightly off-piste here, but the sense of control of your destiny is really important to your positive mental health. Feeling that you are a cog in a machine over which you have no control is really detrimental to your mental health. And I think we all would agree that mental health is a very important part of the health picture. So if you can give patients a sense of control, that they are an equal partner in their care, I think that's a very powerful message and a positive step for their mental health.
And the reality is, a very recent study from the Bichard Institute showed that more than half of the people in this country don't think they're sufficiently involved in decisions about their health or their care.
Well, the way to make them feel more involved is for them to be in control of their care. And one of the ways you do that is by them choosing who they go to and having the means to choose who they go to. And there is a country where the patients do pay largely for their own health care, and that's Singapore. And the big political problem there, of course, that's not what we might call a full democracy. It's very successful, much richer than we are, but it's not a full democracy. So it's where they've managed to do it, which might be more difficult in a full democracy. But the way they've done it is very clever and worth knowing about if you don't already know. They are compelled to have health savings accounts. So if you get a job, immediately money, instead of going into national insurance, where you'll never see it again, it goes into a number of funds, and one of them is a health savings account. Now, when you are ill, it builds up over your lifetime, becomes a very substantial sum of money, even if you're not very highly paid, because the deductions are quite severe, and until you reach different ages, different amounts deducted. And it builds up by the time you're likely to need health care, which is usually when the older part of your life, when you need the hip replacement, you've got a terrific fund. You can just buy it out of your own health savings account. And you can choose which hospital you go to. You can choose whether it's a private one or a state one. And that power to choose means, A, you're empowered, which makes you feel good, but B, people are competing for your custom. So they've got an incentive to make a nice hospital, get a good surgeon, do it promptly, do the kinds of things that people do in a competitive environment, because you have power, the patient has power. And so, I mean, there's no doubt that the Singapore system is much cheaper than ours and it appears to be extremely successful. I visited a hospital in Singapore, which would be an example to most hospitals in Britain that I've ever had the misfortune to visit. But it's a really, I think it's difficult politically, but it is not impossible. And if we move to a health savings account, I think it would be politically very difficult, but I think the results would be outstanding. And if you combine that with insurance, as they have in Singapore, and perhaps will do to an increasing extent, and maybe have some mixture of the Singaporean system and the Swiss system, then I think you'd get a hell of a improvement in our healthcare.
See, the problem I find with James's argument, you see, is I'm a huge admirer. No one could be more admiring of Singapore than I am, actually. And the Singapore Civil Service, I think, is a model for the world to look at in all. But if we're talking about, you added in at the end, this is politically maybe a bit difficult. I mean, we're talking about a system here where we can't even get politicians to face up to the fact that we could perhaps get some money out of by reducing free prescription for the over 60s, let alone all the other things I've talked about. Let's be politically realistic about this. Your system may well be the right system. It ain't going to happen for a very long time, and therefore we've got to find some way of making this system work more effective. Because if we don't, it's the most disadvantaged people in our society who will suffer, and those people will not thank us for having another long-running debate about choice and finance and structure. We haven't talked about structure tonight, but most of the last 20 or 30 years in this country has been around changing the structure of the health service and most of our other public service. The people who miss out are the most disadvantaged in our society.
Can I answer that? I mean, basically you're saying, you're basically saying, let's try and make the system a bit better, because after all, nobody's going to accept a radical change. People have been trying to make the NHS better since it was created. It ran out of money very fast. And ever since, we've had people come up with great master plans. Keith Joseph had a master plan, bringing in management consultants. Over and over again, health secretaries have come out with the answer. And over again, people have longed to believe them. But it's a lie. And we should stop kidding ourselves. It's an awful system. It's a crap system. It makes people die. We should get rid of it.
I think there's also something that we haven't touched on yet, which is the countries that you cite all have far lesser degrees of central control. So in Switzerland, they have the canton system, and in Germany, they have the, do they call them
Bundesländer.
Provinces or?
Bundesländer.
Thank you. And, and so I think there's a really interesting point here, and Switzerland is, and Singapore is just a lot smaller. So I think there's a point here about the scale of decision making, and one of the things that is quite noticeable in the UK is the scale of decision making is up here. It's all up here. It's all in Westminster. It's all in London. It's all central. Whereas in the other countries that we're referring to, the scale of decision making is at a far more local level, where regardless of the funding structures, which I know is kind of your point, James, but regardless of the funding structures, operational integration and operational kind of sensible decision making between the different parts of the ecosystem are far more possible because you literally know them. They work maybe 3 streets away. You can call them up. You can actually get together to redesign services in a far more efficient and functional way. That's incredibly hard to do when the NHS administrators in Grimsby are actually more concerned with what's happening here in Westminster than they are with their colleagues at Grimsby City Council. in order to, at an operational level, change the way the service reacts and ideally prevents healthcare need, you really need to be able to devolve down to a much more local level, which is, I think, a really interesting agenda that's currently running with the Northern Powerhouse and everything that the Chancellor is currently really keen on doing.
It is. I think if you look at the OECD figures, the UK has the most centralised, certainly in terms of tax raising power, has the most centralised country in the world pretty much. 95% of tax revenue is raised at a central level, just 5% at a non-central level. But you'll be pleased to hear, Emily, that last week we released the first paper of the Paragon Initiative, which was called Federal Britain, which had an argument for fundamental fiscal decentralisation to local authorities. We'll take another round of questions now. So I'll do three. So I'll go three on the left-hand side. So the guy in the spectacles there, the Felix in front of him, and then the guy in the hat. Is it a hat? Yeah, the guy in the hat.
I'm Paul Cartwright. I work in the NHS. I'm a NED in a larger acute trust. You've laid all these self-evident truths in front of us, and there's been some exploration of some of the way through them, technology, power to the patient, the Manchester experiment. I was not clear as to how one moves the debate on from its sort of, what I would agree is sort of sterile place at the moment. I mean, it's really depressing in the saloon bar on the pages of the newspaper. What is it? A lack of a charisma, a lack of a political party? What is it that moves the debate beyond the sort of sterile confines where I live at the moment?
Felix.
My name is Felix. I work in the financial regulator, the FCA. My question is about the current fight the Health Secretary, Jeremy Hunt, is having with the BMA, principally, about junior doctors' contracts, which seems to be a relatively small change in the grand scheme of things. Of course, if you're a junior doctor, it's probably quite a large change, but we've seen incredible hostility and opposition to something which seems to be, tinkering at the edges. Surely any more radical change, anything which involves more marketisation, something the BMA have campaigned directly against, is going to trigger doctors' strikes, mass walkouts. And, doctors and nurses are pretty well respected by the public. They're held in pretty high regard. And any fight with the politicians, they're probably going to lose that in the eyes of the public. So how can politicians, even if they are incredibly courageous or whatever, possibly win that fight, or see it as logical to even begin to fight on a bigger scale?
Patrick Frislovich, medical student at Imperial College. I have a question for James, since he mentioned the idea of abolishing NHS, whether he could suggest a potential model for privatisation, and how would that link to the health savings accounts?
Okay, so we've got three very different questions there. So the first one was, what is stopping the debate from moving on? Is it just the wrong people in power, people without charisma, or is there something more fundamental preventing any sort of large-scale change? Anyone like to, Kristian, perhaps you'd like to sort of comment on that?
Yeah, the political difficulty around this is a result of the fact that the NHS is a founding myth of post-war history, in the same way in which, say, the Americans have their Independence Day and the French maybe have Bastille Day. This is the role that the NHS plays here. And what it has in common with the other founding myths is that it is not a true story. I've looked at the way the NHS evolved recently, the early years, the foundation stage, and this idea that there was massive public demand, that people wanted a state-run service, is completely untrue. What happened is it later became popular, and this popularity was then projected backwards into the years in which it was created. But in the beginning, it was an elite project. It was groups like the Fabian Society that had long argued for a state takeover of healthcare. But if you look at opinion surveys from the 1930s and 40s, where people were asked, what is it that you like about the system? What is it that you dislike? What kind of system would you want to have? Almost nobody said, I want government takeover and state-funded healthcare. That's something that, James alluded to this briefly, it was not even the Labour Party. It was, Bevan's almost as a one-man show, bringing this in at a relatively late stage, when the discussions were much more about smaller, pragmatic steps. And then later on, this founding myth was built. Now you could say, well, that's ancient history, that doesn't really matter much more nowadays, but it does, because that's part of what creates this romanticism around it. And that's what makes it harder to discuss failure openly. And that leads on to the question about how would you go about privatization or moving to a more decentralized model at least. Well, even though we talk about the NHS as being a substitute religion, actually, if you look at the British Social Attitudes Survey, where they ask questions of that sort in a bit more detail, there's an interesting divide. If you ask people about their commitment to the NHS in the abstract, almost everybody says, yes, the NHS is great. You get results that are normally difficult to achieve in a democracy, with over 90% having the same opinion. But if you ask more detailed, more specific questions, like where would you want to get your healthcare from? Would you want that to be publicly provided by a for-profit company, by a charity? Turns out most people are, at that level, quite pragmatic. 40% say, well, I don't care. I want my healthcare to be provided by somebody who's good at providing it. Don't care who owns the facilities. And then you also get a substantial minority who actually actively prefer private provision. So what you would have to do is try to find a way of instrumentalizing this pragmatism, this micro-level, lower-level pragmatism, that people are actually quite indifferent about who provides their care, just extending on reforms that have already happened, of giving people greater choice and of money following patients, and applying that more consistently in such a way that you could also have hospital failures, that hospitals can go bankrupt and can be taken over. And that would be a way to move gradually towards a more diverse and more pluralistic system.
The second question was about the current fight, for want of a better word, that the Health Secretary, Jeremy Hunt, is having over the issue of junior contracts. I wonder whether any of the panel want to reflect on that, and perhaps lessons for many of these other more radical changes to the way that health and social care is delivered that we might think about.
I think I thought the first question and the second question were really interesting. How do you actually move this on in a world where you've got so many vested interests and you've got a religion? And there ain't no easy answer to that. It's a really, really good question. And if you don't have really strong political leadership that is prepared to take these vested interests on in the way that Thatcher did on a number of fronts, then maybe you need to look more at managerial official leadership, because a lot of the things I was talking about, you can introduce. You can introduce service design into this system. I know that Simon Stevens believes that, like me, is the only way forward. So get on and do it. You can do more co-design, you can do more co-production. Start under cover, if you like, and just get these things in place. For the political leadership, and the reason that we're missing a trick at the moment, I was a permanent secretary for 5 or 6 years. Please don't throw things at me, but I was the permanent secretary who was responsible for introducing tuition fees. This was a government in '97 who wanted to introduce tuition fees, not my policy, their policy. What I said to them was, you only have one chance to introduce something which is this unpopular, and that's in the first 9 months after the election. No one seems to understand that. If you want to introduce unpopular policies and you've got a majority, do it now, because actually the opportunity's already been lost. So what we don't have is good, effective, strong political leadership, I don't think, at the moment, that understands those sorts of things. So go under the radar and try and introduce these things, through the official machine.
I'd just like to kind of widen it a bit as well, because a lot of what we need to think about is how the public use the NHS. 99% of the public value it like a religion. It's the closest thing we have, and there are probably more people in the NHS A&E on Sunday morning than in church. But I think we need, so there's that, And then at the same time, there's the nature of the demands that are being put on the health service. And many of them have an element in which individual action has both caused the problem and is part of the solution to the problem. And I'm thinking here about obesity, about the drink-related incidents and the health impact of that, the poor lifestyle, unhealthy lifestyle, I mean, and the health complications that come down the line from that. So I think there's actually a role, not just at kind of the technocratic service design or the funding level and do we need a co-payment for drunk people in A&E and charging them £100. There's actually treating the population like an intelligent group of people and saying, guys, we have, collectively speaking, £100 to share for our health system. We need you to help us spend that money wisely, which means not calling on it, doing your best to not call on it in unnecessary ways. I think it's about having a mature national conversation with the population and treating them as co-partners in the transformation of a dearly loved institution, because it is now a different situation than it was when it was initially set up. People kind of got ill and died quickly. That's relatively easy to deal with. It's not so easy to deal with people who get ill for a long time and die slowly, and sadly, unfortunately, sometimes in not as ideal circumstances. So I think it's actually about, there's an element to this which is not technocratic, which is about a national conversation and changing that national myth.
But you can do the two at the same time.
Oh, I think you're entirely
there's a
necessary.
discussion,
It's an and, not an or.
Yeah, and we haven't talked much tonight actually about the balance between response and prevention, but we do not have a culture generally in our public services and certainly in health of prevention rather than responding to an acute crisis.
Yeah. And do you think at the moment the approach to those lifestyles issues treats individuals like adults, or is it a very sort of paternalistic, interventionist model? When we just heard somebody mention the sugar tax and the sort of debate around that.
Oh yeah, I think it kind of looked. My impression is that it swings from one extreme to the other. On the one hand, it's either kind of relatively heavy-handed regulation, or else it's sort of screaming red top finger pointing. Neither of them are, I think we do need to treat the population as intelligent people and as partners on a journey towards change, because this is a very dearly loved institution, and change will be resisted if it's seen to be undermining in a way that's threatening my granny or my ill child, or in any of those very emotive terms. So I don't know the answer to that question, but I do think we need to help as policymakers to help that national debate move on.
There's a great article, if you haven't read it, on Guardian Online last week by Tina Rosenberg about Mexico, which is the obesity capital of the world. And it's really interesting in the way in which that conversation has developed and the way in which major drinks companies have tried to influence it. And we just need to be aware of just how complex these public policy conversations can be and difficult they can be, but I agree with you.
And James, I think you were asked by the chap in the hat how, I think he was asking how you would go about some sort of privatisation, some sort of move towards the Singapore system.
Yeah, well, I mean, you'd have to tell me, but I guess you're thinking partly of hospitals, and how would you pay with a health savings account when they're government hospitals? If that was your mind at all, I would say that the hospitals could be changed like ones in Holland are effectively, because they've actually never changed from being sort of independent trusts. And if you have a health savings account with money that follows you, or you can use, then they could all become independent trusts, or some of them might be sold to private companies. New clinics would set up, and the money could be paid to these independent trusts. I just want to come back to the other point about how we can move the debate on. Of course, the whole purpose, I mean, if you imagine Cameron as a Bond villain stroking his cat, and you imagine Jeremy Hunt as there, he's one around the table, he's one of the people being talked to. And Jeremy Hunt's job was to bury the NHS. The NHS must not be an issue. Make it disappear. Keep quiet. Put soft salve over every issue, if at all possible. he has now failed. He has now allowed these junior doctors to become a major issue. And so I don't know whether he'll stay in his chair or whether he will suddenly it'll drop down and he will die. But I suspect he will survive. But he's obviously failed in mission one.
I think we should just remind ourselves that if you're going to renegotiate junior doctors' contracts, it's quite important to get the right terms in the contracts. I mean, I just remind the audience of the Labour Party's renegotiation of doctors' contracts, which seemed to me to take us further away from what the policy was intended to achieve than ever. So, you know.
Perhaps Tony Blair had had a late night the night before. Perhaps he'd been eating too much sugar or something. Let's have a final round of questions before we... Oh, wow, we've got a lot of questions. So perhaps let's take 4 questions. So we go to the gentleman there, and then we go to Richard behind him, and we'll take 2 on this side. So this gentleman here, and then Solange at the back.
Yeah.
So yes, we start with the gentleman here.
Okay, so I'm John Henderson. I'm a GP, a working GP, and I'm fascinated particularly by Kristian's comments on the poor results in the NHS. And I have to say, working with the NHS, it doesn't surprise me, and it doesn't surprise me because actually, patients or clients, whatever you want to, customers, whatever you want to call them, are the poor relations in the relationship. Why is that? Because they are not the consumer. They're not the consumer because the government is the consumer. So the contract I have with the NHS, I'm an independent contractor. Our body negotiates with the government every year. I get paid for the number of patients on my list. I get paid for doing certain things like your blood pressure and smears and certain other functions. So if you come to me with a sore throat, you're costing me money.
Yeah.
So not surprisingly, I'm not open late in the evening. Not surprisingly, I'm not open at weekends because it would only cost me money. Not surprisingly, there are things all over the wall saying, it's a virus, are you sure you would want to come and see me? You can't handle it yourself. Are you sure a phone call won't do? So a business model designed to deter your customer is one that needs looking at again, I believe. It's dispiriting for patients, and actually it's dispiriting for GPs. I'd love to be open 7 days a week, perhaps unusually amongst my profession, but I'm, if you like, a small businessman. I would very much like to improve the service.
Well, that was some of those things derive from the last renegotiation of the contract, don't they? Because some of the things you do because of the contract. And when my GP rings me up and asks me about when did I last have my blood pressure tested somewhere, I know that he's actually ticking the box that I've had my blood pressure done. You've got to get into the kernel of these things. You've got to understand that if you negotiate a contract, the contract had better encourage people to do what you want them to do and what you think is a priority.
So, we need I think the patients need more empowerment, so whether that means a co-payment or whether that means a social model of insurance, I'd be very in favour of that if that were politically feasible. We need more competition. I mean, I speak slightly against my own profession because more competition means I would have to try harder. But, one of the advantages of general practitioners being independent is that if the incentives change, we change quite quickly. So when the new contract, not so new anymore, came out, one of the things I think that slightly upset the Labour Party is that we achieved our targets really very quickly because that's in our interest to do so. And so they found it rather more expensive than they were expecting. So actually there is hope. If you introduce... I think we need better carrots, and actually we need better sticks as well.
Richard, just behind you.
Richard Clark, I'm just an interested amateur. I've got the dreaded 2-part question, but they're both very, very short. It's just relating to moving on the debate and actually having some political impact. One of the questions I had was, is this the sort of topic that actually you need a Labour government to change things? And I'm thinking of the fact that 5 of the 6% of private provision happened under a Labour government, and for them to make those types of changes is less toxic. And then the second part is something I'm kind of not an expert on and a bit vague about, but it was my understanding that the Richards report recommended that you could have topping up and mix and match of private and public provision, and whether I'm right about that, and 2, whether that was perhaps a beachhead through which you could have a plurality of provision and ultimately a kind of a bit more competition in funding as well.
Okay. Gentleman here.
Yes, hello, my name's James Lefnew. I write a regular weekly column for the Telegraph, and I'm a general practitioner. I just wanted to make a couple of critical comments. The first is, I qualified in 1974 in medicine when the health service, the NHS, was the most cost-effective health service in the Western world, delivering more services per £1 million spent than any other. That situation prevailed and persisted until 1989, and the introduction of the NHS reforms under Kenneth Clark and the competition and the provider-purchaser split, as a result of which, as we all know, introduced the Trojan horse of managerialism and the increase in the number of senior managers by over 1,000% in a period of 5 years. Since then, the NHS expenditure has doubled and doubled again, from 28 billion in 1989 to 48 billion to 86 billion to 110 billion now. And it is very difficult to see, really, what benefit has come from that massive, unbelievable, extraordinary increasing expenditure over that time. My point, obviously, is that this notion that somehow or other the introduction of competition is some panacea for the problems of the health service is contradicted by our historical experience. And although I am not, obviously I don't think that we can obviously return to a status quo ante. We have to remember the extraordinary strengths of the health service in its original formation, and particularly the simplicity of its organisation, with the division between primary healthcare services providing long-term care and giving access to the acute services. And so I am unbelievably unimpressed by James Bartholomew and Mr. Niemietz. It is contrary to every single 40 years in the health service. And I would rather take up Lord Bichard's point. The point is that we have to do good in minute particulars here. We have to focus on those particular aspects of the health service which are reformable. And the notion of introducing that there is some better system is a complete absurdity. It's contrary to our culture. It is politically futile. And I do think that the IEA should get a bit wise about this, because the IEA was, of course, instrumental and very active in promoting the purchaser-provider split and the NHS reforms of 1989, which everybody admits was a complete disaster. And so it seems sensible to at least take that on board, take that historical context on board, and move on from there. Thanks very much.
That was a bit before my time, unfortunately. We'll take a final question from Salaj.
Look, we're doing a swap over here. I'm Terry Barnes. I'm a visiting policy analyst from Australia, actually. And I just wanted to make, and thank you for giving me the opportunity, a quick comment to you. Last year in Australia, we had a very difficult debate about introducing a mandatory GP co-payment of $5, and it started from a think tank paper which I actually happened to write, which eventually brought down effectively a Prime Minister a couple of months ago. So I think
hope that's on your
CV. But the point I'm making is
that a credit?
The point I'm making is that the politics of even simple change and sending messages about the cost of providing care in the ecosystem of the NHS is similar to ours, with some differences, is actually very difficult. And the other point I wanted to make is that we talk about the politics. It's not the politics of government that, certainly in our system, I suspect here as well, that is the problem. It's the politics of opposition. When the opposition of the day, whether it's Conservative or Labor, can basically press the hot buttons, say elective surgery waiting lists, access to specialists, GPs, doctors and nurses, bricks and mortar issues, public hospitals and so forth. Even though that if we're talking about the best models of care, that paradigm is basically very 20th century obsolete. But that's where the pollsters say that the reactions are, that's where the votes are. We're not going to get the type of change that I've heard talk about tonight. So I'd just be interested to see what your views on that are, but if you want to talk about experiences of managing even simple change in a similar system, come and talk to me.
So before we go back to the other questions, anybody got any reflections on that point?
Sorry, I got carried away.
Yes, I think he's right. I mean, so the politics of opposition, and that in fact goes back to one of the other points raised. That yes, it would be a nice idea if Labour took up this idea. Obviously not under Corbyn, but you know, if you had a Blairite came back and said, actually, this isn't working well, and we as the Labour Party are going to take on some market reform, then yeah, I think that would be the ideal scenario. I mean, it is the Nixon-China thing, isn't it? You know, it's a cliche, but it's true. On the other hand, in welfare, you know, where you'd think the only people with the right credibility to reform welfare had to be the Labour Party, they didn't. They not us, thank you very much, and passed on, and actually the Tories have actually done it, and had a surprising amount of support that nobody imagined they would have.
And what about the chap who laid the blame for all the NHS's failures at the IEA's door?
Well, James, he's a redoubtable chap. I have enormous love and respect. But I think you're over mesmerised by the 1989 experience. It's obviously been traumatic. The point is that the reason why 1989 was attempted was because, yet again, the NHS was doing so bad. Don't forget all the hundreds of hospitals which were being closed in the 1970s. Hundreds of hospitals in a rush. That's absolutely true. And the reason that it was yet another of the attempts to make the model work. It's trying to make the elephant run like a horse. And it was another effort that failed. And that is precisely what I mean. And it was not a real market. It was a mimic market. And this was some American guy, was it Enthoven, or what's his name, who had this theory, you know, we can make a Zatz market. It was a real market. Now, if you would raise your eyes above Britain and look abroad, travel a bit, you will go to places like Switzerland and you will see there is a real market. And that works much better.
Yes, James, but the point is, of course, that Switzerland has a population, a homogenous population of approximately 10 million.
Yeah.
Or pretty well educated, upper middle class and so on. That is not the situation in Britain. The notion that somehow or other, Britain's problems can be solved by looking at someone like Switzerland, it's a sort of political fantasy.
I don't want to spend the whole evening disagreeing with James, but I think your analysis of the issues around welfare, reform and health is deeply flawed. I think this government were quite clear and quite right that there was actually a majority out there that wanted some reform of the welfare system. And they have been, and it was absolutely right to reform it. I'm the poor mug who tried to deliver it for 5 years. And it was almost an impossible system to deliver. It needed reforming, but they knew that they had support from the majority of people. Okay, they've hit a bit of a blip with tax credit as a result of my colleagues in the House, but it's a completely different situation to try and attack what is regarded as a religion in the health service. I'm picking out one or two of the points and then I'll shut up. I think one of the sadnesses is that a lot of the political energy of the last 30 years, which ought to have been put into moving this system forward gradually, better outcomes, better patient focus, has been wasted on competition, choice and structure. Those are the debates. And I know why that is, partly for dogmatic reasons, but also because if you start playing around with structure, if you're a politician or a senior civil servant who looks, have you done something? And it takes 5 or 6 years to find out you haven't done anything at all apart from disrupt the system and achieve nothing at all. So the political energy that should have been put into the kind of things I'm looking at my friend at the back, and I would want to see, has actually been wasted on things that have had no impact.
And perhaps, Kristian, you'd just like to reflect on, how effective some of these quasi-market reforms, I guess you'd describe them, since 1989 have been?
Well, I'm a bit more optimistic about them. There have been quite a few studies from the LSE that looked at what happened after the introduction of this quasi-market. And yes, of course, I'd also prefer a real market, but even to the limited degree that people have been able to make choices and that the money followed them, there is quite a lot of evidence that in those areas where competition was more intense, because you had simply a greater number of providers in a smaller radius, their outcomes have improved quicker compared to the areas in which competition was more limited, simply because they were sparsely populated or whatever it was. So even in a quasi-market, competition does still work. And at the very least, it can be a first step towards real competition. So what we have seen is there was initially the belief that it wouldn't make a difference anyway because patients are too ignorant. They cannot judge the quality of different providers. Healthcare is too difficult an issue. But actually, patient movements after the introduction of choice are quite highly correlated to outcome measures, quality measures of the hospital trust. Now that doesn't mean that lots of people download data from hospitals on standardized mortality rates or something, but it just means that softer measures of quality are somehow correlated to those harder ones, that people maybe ask others about their experience, or that it somehow enters the reputation of a provider. But you don't have to be perfectly informed for competition to work. And it is actually the case in most market segments, most sectors, that we are quite poorly informed. If you buy a computer, yes, of course, you could read a testing consumer magazine, you could look at how does it do on this measure and that measure, but how many people do that? Most of us don't, because it's just boring. We rely on heuristics, on relatively simplified ways of making that choice, brand reputation being one of them, and that is a way in which healthcare can work as well. You don't have to have perfectly rational homo economicus consumers. Competition can work even with relatively limited set of information, and even the quasi-market has been an improvement compared to the status quo ante.
Well, like George Osborne missing his deficit targets, I've missed my target to finish on time at 8 o'clock. But I'm sure this is going to be an issue that's going to run and run over this Parliament, and indeed in the decades to follow, given the challenges that we're going to face with an ageing population, the pressure that puts both on the public finances and the type of care being delivered. It's just a House announcement before I thank the speakers tonight. On Wednesday, the 2nd of December, we've got our annual Hayek lecture this year. It's being delivered by Bill Easterly on the topic of foreign aid. So we hope to see as many of you as possible attend that. But it's just left to me to thank the speakers for giving up their time to be with us this evening. Thank you to Kristian, to Michael, to James and to Emily. And if you could give them a send-off in the usual way, that would be much appreciated.